Parity conversation panel. Stan may repeat me, I don't want to, whatever, but Stan. Mrs. Carter in 2008, as I mentioned in my opening statement, was really instrumental in passing the Mental Health Parity and Substance Use Equity Act. As she said about 4 or 6 months ago, and when we were working with Morehouse, Megan and her colleagues, and the report card, and we took ownership of writing the consumer guide to a technical report that Morehouse had written. And I was sharing this with Mrs. Carter. She was just like, Eve, Georgia has a D? I said, yes, Mrs. Carter, and we're gonna look into this. And I got like a brick hit me on the head when I was walking around Washington, D.C., and I was like, how could this be 10 years? And there are all of these states still failing. And this is something that the Carter Center needs to roll up its sleeves and work with our colleagues. So we have begun to assemble a team, those of which are on this panel today, to really develop a strategy around this. So we're going to share with you kind of what we know to date. And as I said in my budget meeting this last week, we're not going to go from a D to a B. We're going to make Mrs. Carter proud and go to an A in Georgia. So with that, Stan, it's all yours.
Well, now we're all preaching to the choir. I think the altos and sopranos have left. Save insurance for last. This last panel's between a nap and Mother's Day. We are the nap. So for me in my life, it's been really fun to have worked for Rosalynn a couple of times as a staff person to the Georgia Commission in 1971, and worked also on the Presidential Commission on Mental Health when she and Jimmy were president. I like to say it that way. They were governor together, they were president together. I've done this a long time. I felt often that I was, too dangerous to speak at the symposium. So I think there are 3 reasons for that. So I'm a lawyer lobbyist. We talk too much. I have a tendency to public profanity, which I intend to keep in check. And most things I say are sort of half-baked, or based on half the facts, or half-based. So in the profanity theme, there are a couple of other ways to say that. No, that was flat, sorry. But we often get asked, or I get asked, why are you interested in all this? Because it's been a 5-decade passion right now. And so one of the things I say is that, I was a nerd. I have suffered from some mild depression. I was a nerd. Nerds can't get a date. That was even worse, sorry. But what I really like to say is just lucky, I guess. When the history of the Georgia Mental Health Commissions is fairly interesting, at least to me. So it all started really in 1959 when Jack Nelson won a Pulitzer Prize for exposing illegal surgery at Central State Hospital. It was the biggest asylum in the world. Governor Vandiver set up a group to study that and come up with some other things to do. And a lawyer named John Moore was the lawyer for the Medical Association, so he chaired the Vandiver Commission. So he was, and Rosalynn invited him to also chair the commission while she and Jimmy were governor. He was very interested also in mental health, and he had hired, or planned to hire, an associate who was joining his law firm to be the staff person for the commission. Well, lo and behold, he got drafted. So his fiance called me up and said, you might be interested in this job. So my family had been around politics, helped the Carters and the Carl Sanders. And so that's why I say I'm just lucky, I guess, because that was my opportunity to get involved in this. We're going to try to talk about mental health parity generally. These folks have been involved, both state and federal environments, in trying to sort of understand what implementation means 10 years out and what it means at the state level. This isn't the easiest topic. We're going to talk about some things and not about others. That reminds me of my favorite joke where the CEO is having morale problems in his company and he invites the employment consultant, to come help him out. So the consultant, she says to him, well, please list all your employees broken down by age, sex, and race. He thinks for himself, well, that would be all of them. So we won't talk as much about equity directly. You've already heard about the elderly, and I'll stop very shortly. But we're each going to talk 8 or 10 minutes, 6 minutes, and then have questions among ourselves and certainly invite questions from you. When Ms. Carter said, I want to get involved in state equity, mental health equity issues, it's not the easiest thing, to decide what that means. So it might mean, does the state have its own state equity law? It might mean, how well are insurance companies doing in your state in implementing the federal act? It could mean, what are the pieces what are still the gaps on insurance issues? So we're going to try to talk about those. If you've ever sat through an insurance committee meeting, you are cured of insomnia. So insurance is complicated, it is dry. I'm going to say a few ways in which it's organized that perhaps will help the discussion. So there have been some references already today. Insurance really is sort of, all gall is in 3 parts. So you have large group, small group, individual insurance. And each one is a little bit different. The state tends to regulate these individual insurance products and the smaller group insurance products that are not part of the federal regulation through ERISA and through the parity issues. Insurance used to be called accident and sickness insurance. Health insurance was. And so that has a particular limitation. It's about, is there something physically wrong with you in the short term? And that didn't mean usually chronic conditions. So insurance companies offer a product, they can sort of define it as they choose, subject to state law mandates. And so they would exclude things that were more expensive. That's changed over time. We had health plans after reimbursement for accidents or sickness. That implied a little bit more carefulness in thinking about what the insurance company was going to pay for. It was different than reimbursing, a physician, a hospital for whatever the physician ordered. That was accident and sickness. Then we had health plans. We have health maintenance organizations. The word maintenance, has a little bit different orientation or connotation. It's more oriented to prevention, for example. Insurance is reimbursement. It's not a health system that delivers care. I think sometimes in the single payer discussion, people equate having a major financer, the federal government, of health insurance with the government employees delivering health care. That's what happens in Britain and other parts of Europe. Self-pay means that you have one definition of what's going to be paid for. It's usually administered by the private insurance companies who've converted from insurance companies to third-party administrators. And so it just has a different feel to it than it's, widely believed, what it's widely believed to do. I think most people know these terms, but in the parity discussion, we talk a lot about deductibles, copay, co-insurance, and lifetime caps. So just for some explanation, the deductible, of course, is what you pay when you walk in. It's a set amount. Deductible is the amount for which before you are entitled to reimbursement. It's an interesting issue. If you have some of the newer plans on the health exchanges that cost $5,000 before you receive anything, insurance may not actually give you very much. At least it doesn't for the routine things, but it's very relevant for major accidents, surgeries, and mental health. Copay is the set amount you pay. I think most people realize that. They experience it all the time. Co-insurance, is the portion of the cost of a procedure that you pay that the companies have defined. And also there are lifetime and annual caps on how much a company will pay. So some people don't quite realize that. You kind of get used to, you got $20,000 of primary care coverage. You go to the doctor 10 times, maybe the hospital once, and it costs $30,000, let's say. Well, actually, in most insurance products, there's a limit on how much of that money you can spend. And so those ideas are relevant to what the history of parity is. The first thing we've referred to a couple of times is the Mental Health Parity Act of '96. It was trying to equalize the annual limits and the lifetime limits for mental health. One thing that not everybody realizes is that the use of parity or the requirement for parity is optional. It only applies if the insurer chooses to offer mental health benefits. So there can be a gap if the insurance company, the employer, don't have to decide to cover mental health services or addiction services. Now most do, who realize that their workforce is more productive if they're also helping them with more serious conditions, and particularly around mental health. The 2008 Act sort of widened that a little bit. It talked more about things that need to be included in a mental health package, not just that there was the same payment mechanisms for mental health and physical health. The Affordable Care Act, and this is really for the first time, and it moves a little bit past the optional nature of whether you're getting any benefits. It's set up as essential health benefits for the health insurance exchange products, and mental health had to be included, and then it had to conform with parity. With that background, we've been struggling with thinking about, well, what's missing? So at the state level, the State Insurance Commissioner regulates plans that are not covered by the federal ERISA laws, that are not self-insured. And then that's typically very small groups and individual insurance policies. There's some other things, though, that people don't think about, and it's not just the gap. Not just does the state have its own state mental health parity law, but what are other things that might be missing? And I just want to mention a couple of them now because we're about to embark on a pretty wide discussion in Georgia about what does the waiver for patients who are, for citizens eligible for Medicaid up to 100% of their poverty level, what are they actually going to get? So there's some other things that are interested in they need to be in the discussion. They're not directly parity. Is there equality between physical and mental health? But it's very important what the benefit plan includes. So I think earlier this morning, I think it was Susan Geico, she listed the things in the settlement, right? And she went through about 10 things on the behavioral health side included: assertive community treatment, walk-in behavioral health crisis center, crisis stabilization unit, housing, supported employment. When you look at insurance issues, we know those things work best in helping people in recovery. If people have a job, if they have a safe place to live, they're more likely to take the appropriate medications, attend counseling, use their peers to talk to. Well, not all those things are necessarily included in the benefit package that's in Medicaid, for example, or Medicare, or whatever's going to happen in the issues going forward as we define more people that are going to be helped by Medicaid. Another thing that's sort of interesting, it's got some history to it, is what's the definition of medical necessity? So, in accident and sickness insurance, we didn't have a definition. The insurance company paid for what the doctor ordered. Health plans have started getting more careful. Is what the doctor ordered actually necessary by some objective standard to be paid for? That was based in some ways on sort of unjustified concern about doctors, seeking more procedures. I don't think that's entirely fair, but that was sort of the origin of that. Then, as you get deeper into things, you realize, okay, we're covering more people. Maybe we're covering people who are disabled. We're covering people who are autistic, covering people who suffer from mental illness. Well, how are you going to define medical necessity for that? And it's an interesting question. So, we left out the people who suffer from chronic illness because it wasn't an accident or it wasn't sickness. We've moved past that. But how you define who's eligible for the reimbursement from the insurance company, a lot of it rests on the definition of the medical necessity. And there's some differences there. So you can define severe mental illness in a range of ways. If it's broad, you pay for more things. If it's narrow, you help fewer people. One example of something like that is the definition of how Medicaid helps handicapped kids or disabled kids, developmental disabilities or intellectual disabilities. It asks, is the proposed course of treatment going to ameliorate or keep from deteriorating the condition that the kid suffers from? It's mostly around children. So, that's a much wider way to look at what are we going to pay for and what do people really need. So as we move into these things in more intensity, particularly in Georgia, it's important to say, what are we going to pay for? What are the things that work best to keep people in recovery? And some of that's job support. So that's not to some people, that's not a healthcare service. If you think about helping people get better, that's important. So some programs have life coaches, some have job coaches. Everybody has case management, which is more active sort of assessment of whether the patient's complying with whatever's been ordered. There's something new now in the last few years called care coordination. So you have somebody who may not be a licensed health professional, maybe not a caseworker, social worker, or a licensed counselor, but they're calling people to check up on them. We know all these things help people recover better and get them to a place where they can enjoy their lives. But not all of those are included in what is part of insurance unless you work at it. So here in Georgia, we're about to enter an active discussion about covering additional people and maybe rethinking our benefit package too. We'll comply with general parity issues, but there's a wider range of things to talk about. So we're going to talk about some national efforts to assess parity, some things going on at the Georgia level, some conversation about why it's important. So Ben, I think you're going to start. Ben is the Chief Strategy Officer for the Wellbeing Trust, and I think you're more focused on the national definitions.
Thanks, Stan, and thanks for reminding us how complex this is. And I just want to challenge us to think this through for a minute. Does it have to be? Because, we made a lot of decisions over the years that I think inadvertently have put us in this position that we're in now. And it's one of the cruelest ironies that exist right now for people seeking care is they have to work extremely hard to demonstrate that the care that they need and deserve is actually what they can get. They have to work too hard for it. So the burden of proof is placed on the wrong person. And this is a problem. It's a problem for thousands of folks every day in Georgia and across the country. So thanks, Dr. Bird, Mrs. Carter. This is a tremendous honor to be here. I want you just for a second to think about the last time you encountered anything in the healthcare system. Did you know when you had that encounter that your health insurance was going to adequately cover what you were having done for you? Were you able to walk into that meeting and say, okay, this is how much I'm going to pay out of pocket, or this is how much I'm going to get a bill for, or whatever it might be? Most of us have no clue the answers to those questions until we are on the other side of it, where we're recovering from whatever the sickness or the crisis, and then we get the bill in the mail, and we're just like, I don't understand. Now, this is where I think we failed each of us. We failed each other. Is that when you're trying to recover from a crisis or a chronic disease or fill in the blank, and you get that bill in the mail, what do you think that does to your overall emotional well-being? Probably doesn't help it very much. And then when you're in the middle of the crisis and you're trying to help your kid or your parent, and you're having to go through and figure out, well, who do I call? And is this actually covered? And am I in network? Am I out of network? That to me is where we have gone wrong, to Stan's point. It's gotten too complex. So I didn't mean to talk about that, but I get fired up talking. I talk about health insurance on Friday nights over pizza. So this is what you get with me, guys.
I hope you get an invitation for dinner.
I'm going to invite you, Stan, because your humor is amazing, and I want you around more often. Thank you. So just for a second, I want to take you back in history, and Stan did a really nice job at this. I just want to give you kind of 2 data points that I think are extremely helpful when you're trying to get a good sense of how we got to the place we are for parity. First data point, 1963. Okay, if you're in the mental health field, you know 1963 because that's when JFK said, all right, let's get everybody out of the hospital, let's put them in the community because it's better for folks. Okay? The problem is that 1963 and then 1965, when we had Medicare and Medicaid hit the scene, we didn't necessarily know all the things that we know now. Such as, there was really no such thing as a mental health benefit before 1963. We had to make it up. And so when you make things up, unfortunately, they get siloed. And that's what happened with mental health and addiction benefits. So you could take it back 50 plus years ago and realize why we're in the position we're in now. We are still playing catch up from those decisions that were made a long time ago. So when we talk today about how bad we're doing or what we could do to make it better, I just want you to know that the two things that each of us are fighting against every day are culture and history. Okay, that's hard to change. It doesn't mean we can change. It doesn't mean you can't put policy around it and regulation and evidence and all this other good stuff. It just means that making that change means that you're going to have to change a whole lot of language, and you're going to have to get people to think differently about stuff. So what you see on this map here above me is work, and Megan's going to go into more detail here about this in a second, work that we did in partnership with many folks at this table and in the room to assess how well our state's doing enforcing mental health parity through state statute. And what we found, and you can tell by the red, it's not very good. 32 states were failing. Now this map is already changing colors as we speak, and it's one of the reasons you do report cards, because it's an opportunity to publicly shame people and get them to see that they can do better. Well, Colorado just this last week passed a major piece of legislation that is now on par with Illinois as the strongest in the country for enforcing mental health parity. So you've got two examples where the language has already been written that you can take home to whatever your state is, hopefully it would be Georgia, and you can say, this is what we can do. You don't even have to, this is a cut and paste exercise. It's not that easy, but it's almost a cut and paste exercise. The language is there. And so what we wanted to learn from this is what can we do better, and how can we use the issues of coverage and parity to have a larger conversation around mental health in this country. If you don't have coverage, unfortunately, folks, most people will not seek care. Actually, those that have coverage still, I pulled this stat just a minute ago, 64% of folks that still have insurance avoid seeking care because they're worried about how much it's going to cost. So you're that mom, you're the dad, you're the person in crisis, and you don't want to seek care because you're afraid of how much it's going to cost? It's terrifying. So I work for a national foundation, and our mission is to advance the mental, social, spiritual health of the nation. We're all over the country. We get to work with amazing people, and we get to do deep dives into states. And one of the things that we're bringing forward is a framework around how to advance mental health. The cornerstone of this framework, like any good policy agenda, is around coverage. And so we start with parity, but we say, and you can see this at the title of the slide, parity in law is one thing, which is what we'll talk a lot about today. But parity in principle is a totally different thing. And that's where we're trying to change the conversation. How do you equate mental health, unequivocally across the board to be on par with everything that we talk about for healthcare? Right now, it's typically an afterthought or something that we come to later. Oh, I forgot about that mental health. It was analogous to conversations that we were having earlier about kids or older adults. Oh, wait a minute, but what about? We can't do that for mental health right now and be successful in our communities. It will just not work. So we have to do coverage. We also have to do something around access, because just because you have coverage doesn't mean you can get a provider or a clinician that's going to be able to see you. And wait for it, and this is the biggest problem I think most states, is that we ask for our patients, our communities, to continue to come to us. I heard great examples today of going to them. That's the future, and it's another one of these kind of ways that we talk about it. But how do you integrate mental health seamlessly, thank you, into the fabric of all we're doing within our redesign, but then disintegrate it back into community, where the people are. The people who can't take off time from work, who can't figure out a way to get their kids childcare so they can come see you. That's an access issue, and it requires us to fundamentally rethink how we're delivering mental health services. The third piece is that all of this is lost if we don't have good quality care. So again, I can give you coverage, I can hold you to a standard of parity, I can give you a clinician that's going to be able to talk to you and hopefully help you, but what happens if there's no standard of what comes next? Of what the outcomes you're expecting as an individual? I'm a clinical psychologist, and I can speak for at least part of my field and say that not all of us are very good at what we do. It's probably blasphemy. I'm sorry if you're a clinical psychologist and you're very good at what you do. I'm just going to say that it's a lottery as to what you're going to get many times. How do you change that entire structure through your benefits design, through your ways of delivery and financing to give good, high-quality care to everyone? It's a challenge. This is what everybody every day confronts. And I'm giving you this in the context of parity because I want you to see that once we get past that initial hurdle of just understanding if our benefits are actually going to cover what we're doing, we still have to navigate this morass of a system. And so if you just kind of follow along here with me and you start on the left, the entry point, people present with mental health and addiction needs all over the community. Very rarely is it in a place like a mental health center, because usually by the time you get there, someone's referred you to go there. Okay, now that may be totally different in some parts of your state. I'm not trying to overgeneralize here. But each one of these entry points for an individual requires us to assess, is what I'm receiving here going to be covered by my benefit? Is the person that's going to be helping me with whatever I might need, competent enough to give me the outcome that I deserve? And then most importantly, at the end of this, how do I get out of this mess once I got into it? Something we don't like to talk about in healthcare. Okay, how do you, once you've entered into the healthcare system, how do you get out of it and engage these amazing community recovery teams, peer support services, whatever you want to call it, wherever you are, how do you extricate yourself from this mess? This is the vision, okay, that we are able to seamlessly provide care for wherever people show up. We're able to identify a kid's need when they're in school and then do something that day about it instead of say, hey, thank you for telling me that you have a lot of problems. Come back next week when, whoever's here. That doesn't work for anybody. And I will just say this, I'll conclude with just this comment. 96 million Americans last year had to wait more than a week to see a mental health clinician. Now, not all of that is because we haven't enforced parity. Not all of that is because we haven't put the clinicians in the right place. A lot of that is just because we have a backlog of need in our mental health centers, in our communities, that we cannot decrease that gap. How do we begin to focus on prevention and start closing the prevention gap rather than just always focus on the treatment gap? It's a totally different way of thinking about how we approach what we're doing. And when we come to this realized vision together as a community, Georgia can lead the nation for mental health. But it starts with the basic things. And I'll let Megan talk about those.
So I would like to just add one thing.
Please.
I think the Parity Act, the Community Mental Health Centers Act, were sort of key things in the last 5 decades. Well, the Mental Health Centers Act was actually led by a Georgian. So Buffalo Jones, he was working for President Kennedy. His wife had suffered a suicide death. He was very interested himself, and he actually wrote that. And of course, Rosalyn's role in Parity is pretty prominent.
Well, thank you. I'm really excited to be here today and to talk about some of the work. Ben, thank you for kind of giving a little intro into that, and I will go into a little bit more detail about that project. So the Kennedy-Satcher Center for Mental Health Equity at Morehouse School of Medicine is a partnership between Patrick Kennedy, who is one of the huge champions at the federal level to get the federal parity law passed, and Dr. David Satcher, 16th Surgeon General of the United States, who published a Surgeon General report on mental health at the time. So recognizing that the federal law had been passed 10 years prior, last year, we decided to undertake a study looking at some of the state laws related to parity. And just some of what Stan was talking about, how the different sectors of the insurance market are split up. Approximately 26% of the US population, or 87 million people, are impacted by state insurance regulations. However, that is a little bit of an undercount, in that even some of what we found with the state statutes did apply to Medicaid, and lots going on with regard to parity in the Medicaid program as well. But so in recognition of that 10 years, we did this study and again assigned report card grades for a number of reasons, but one major reason being that is a easy way for people to really look at a national landscape of how states compare to each other. And we didn't go into this study thinking that 32 states would fail according to our criteria, which we relied on national level experts who have been working in the field of parity for many years, even before the federal law was passed, to really guide us on what key areas we were going to assess these states. So our assessment, we did look at 10 key areas within the state statutes, and I just want to clarify that again, we looked at the state statutes, we didn't look at regulations or any kind of implementation other than the language that was included in the statutes. But some of those key areas that we did look at included the types of insurance plans, the different sectors that Stan was talking about, and again, not to get too much into the complexity there, but even where the federal government may have regulatory authority over some plans, some of the state statutes do go into enforcing some of those federal laws, and so it's not really a clear, distinction between who has authority. But so the state language did get a lot more specific and crossing some of those sectors. Another one of the key criteria that we looked at was around the types of treatments that the state statutes require insurance companies to cover, the treatment limits. It's a lot clearer where there are quantitative treatment limits, some of the co-pays and visit limits, but non-quantitative treatment limits is really where there's a lot more gray area, and the federal regulations have covered those. But we saw a lot of variation with the state statutes there. And then the mandated benefit piece. In the federal parity law, as Stan mentioned, it's not a mandate that insurance plans cover treatment for mental illness or addiction. But in a number of state laws, and actually a majority of the state statutes that we looked at, they did require the plans that they were regulating to cover, or at least offer to cover, these treatments. So that's where one place that we can see that states went a little bit beyond the federal law. And then we did ask a number of questions about enforcement and compliance, trying to get into what does the statute require with regard to enforcement and compliance, not necessarily understanding what the states are doing. But so all in all, and if we could have just cut and pasted, that would have made the job a lot easier, but we ended up looking at more than 300 statutes. So within the 50 states, there were at least 300 statutes that were related to parity. We found a lot of variation across these state laws, and being an academic institution focused on health equity, this was a really important piece for the methodology that we used to undertake this study, to be able to really compare apples to apples across these states. So seeing that variation will set us up to then do evaluation studies to look at whether these granular provisions of the statutes actually have an impact on the outcomes that we care about. So as Ben mentioned, and you can see on this map, 32 states failed based on our 10 key areas. In total, 43 states received a D or an F. Georgia did get a D, and we, across all that variation, did really see some themes arise for where these states were losing points. 3 of those key areas where states were really losing points were how they're defining mental illness and addiction. We saw a continuum of definitions from a very broad and inclusive definition, which aligned with the DSM without any exceptions in the state statute, to some states that had no definition at all, which actually mirrors the federal parity law that I think the politics got in the way of actually defining in the federal parity law. But that means that the health insurance plans are defining what mental illness and addiction means, and therefore what is covered. We also saw a lot of variation and loss of points in the treatment limits, specifically those non-quantitative treatment limits like medical necessity, prior authorization, and I think a really hard one, the network adequacy requirement. Again, that continuum, we saw some states that specifically banned different non-quantitative treatment limits for mental illness and addiction treatment versus other medical conditions. And then we saw some state statutes that specifically allowed for different non-quantitative treatment limits. So the federal regulations I mentioned are pretty clear on defining non-quantitative treatment limits and banning those different limitations, but lots of different ways that states are going about this within their statutes. And then the enforcement and compliance. We had 3 of our coding questions were related to enforcement and compliance. about whether and to what degree the state agencies, the insurance commissioner or the Medicaid agency, are required to enforce parity, whether the state agencies are required to submit reports on their efforts for compliance, and then also whether the insurance plans themselves are required to report on their compliance. Again, lots of states doing things very differently, but really important point from the perspective of the statutes there for enforcement and compliance. We wanted to target the statutes first because that really is the foundation for the implementation activities that we're seeing within the states. And that is not to say, and we know very, very well, that a number of states who received low scores may be doing a lot of really good work in their regulatory, administrative, and other implementation areas. And then we also know that states that received really high scores, or better scores, may not be doing so much with regard to implementation. So we definitely understand that this was really the first bite of a very large and complex animal, and looking forward to continuing some of this research. We also know that our study was limited to those 10 areas that we looked at, which those 10 areas have been kind of the basis for parity from the beginning of this discussion, but definitely left a lot of innovative ways that states are structuring their state statutes. So looking at ways that we can actually capture some of that innovation in something like this. And then we're really looking forward in the future to, and again, the reason that we structured our study this way, to evaluate the impact of having a strong or comprehensive state law versus having a less comprehensive state law. And there is not much literature on how these types of laws impact different populations within a state based on race and ethnicity, based on rural and urban populations, based on socioeconomic status. In fact, I just found out today I'll be partnering with a colleague from Augusta University. We're going to be looking at the impact of these state laws on outcomes. We have some longitudinal data for children, so we're going to be able to actually look over time how these state statutes have impacted outcome for children. And then being able to focus on Medicaid. I mean, how Medicaid is required to comply with parity and what they're doing to enforce parity in managed care is a whole different beast from what we're looking at with regard to the private insurance market. So being able to assess in a better and, again, more comparable way what Medicaid programs are doing. And then really looking at implementation, which I'm excited to hear from our other panelists who are going to talk about what this actually means on the ground and how this is impacting the communities in Georgia. And then again, that innovative piece. It's been really exciting to hear some of the things that we're doing in the state that are on the more innovative side, or some of the laws that have been passed more recently since the federal parity law and the Affordable Care Act. So really thinking about how we can incorporate some of that innovation and measuring the impact and identifying what is most effective for ensuring access to treatment.
So one thing I'd have in mind for the Georgia advocacy community is taking this list and sort of identifying what we don't have. So there are some things we do have, but we have an autism mandate would be one example. There are a lot of maternal health mandates.
And telemedicine, that's one of
right.
the areas that we've been hearing, and we know there's a lot of work happening with telemedicine and other technologies.
Laura Colbert runs Georgians for a Healthy Future, very interesting advocacy organization, talked mostly about Medicaid coverage over the years. But I think one interesting thing about Georgians for a Healthy Future, you know, it started out sort of pushing the envelope in a wide range of topics, but 2 years ago they were invited to sit on one of the study committees over the summer on healthcare access. I like that as an innovation, you know, when we're inviting experts to join our legislators in study committees. So I've admired what y'all have done.
Thank you. I'm Laura Colbert. I'm the Executive Director at Georgians for a Healthy Future. And for those of you who aren't familiar with our organization, we are a consumer health advocacy and policy organization. And what that means is we really work through state policy to get to a day where all Georgians have access to affordable, high-quality health care so that they can lead healthy lives and contribute to the health of their communities. So we were founded in 2008, which, as you might remember, is the same year the Mental Health Parity Law was passed, and also 2 years before the Affordable Care Act was passed. For that reason, we have a long history of working around insurance coverage, both Medicaid and private insurance. As part of my role as Executive Director for GHF, I also am a consumer representative to the National Association for Insurance Commissioners. And if you want to talk about dry meetings, their meetings are from Fridays to Mondays, so they're over the weekend. And we talk insurance regulation in detail. So if you guys want a real party, you're welcome to join me at one of those. They convene 3 times a year, so there's plenty of opportunities. So we do have a long history of work in insurance coverage, and have worked around issues that are kind of related to parity and touch parity. And in recent years, we have developed more of a portfolio around mental health and behavioral health. So we come to parity really through 2 pathways. One is that we have a long-standing partnership with the Georgia Council on Substance Abuse. We've worked with them for a long time to use state policy change to better prevent and address youth substance use disorders. So over the last number of years, we have had great success with policy change within the Medicaid program, but we keep kind of running into parity as an issue in the project, and needing better implementation and enforcement in Georgia, and kind of seeing how that can be a barrier to care or prevention for youth across the state. At the same time, we do a lot of our work through Coalition, and because of that, we have amazing partners at Mental Health America of Georgia, NAMI of Georgia, and the American Foundation for Suicide Prevention, Georgia chapter. And we get to convene with them pretty regularly, and they have really been pushing for Georgia to pass a parity legislation. And so we are on this panel today, or I'm on this panel today to kind of talk to you about what we're doing to kind of help push that along. And we felt like it was really important before going headlong into advocacy for a piece of legislation to take a step back and look at Georgia's D score and figure out where we are. What does that D really mean for Georgia? So we know that clearly our statutes are lacking. But what else is happening in Georgia around parity or isn't happening? And then how does that create a pathway forward for advocates as well as decision makers and consumers? So what we're doing right now is we've kind of done some initial research around behavioral health parity. Again, we come from an insurance background, not a behavioral health background necessarily, and so we're kind of getting up and running on what the mental health parity law means and how that intersects with other policies that we've had experience with. We have also interviewed both national and state mental health advocates. So we have had some great key informant interviews with some of the folks that we get to sit at the table with here in the state, but also with national folks like those at the Kennedy Forum and the American Psychiatric Association, who have a lot of experience in state parity laws. So we've interviewed them about kind of what states are doing, what states are leading the way. Illinois and Colorado do come up quite a bit. And what does it take to get to that kind of that leadership point? Or what are they doing differently than what Georgia is? Do they have some sense of what's happening here on the ground? And of course our state advocates have a good feeling and sense about that because they interact regularly with consumers and families, and I'm looking forward to hearing from Chris because he is a consumer and is going to share some experience related to that. And so again, we've done this series of interviews. Next we have a series of interviews that we are scheduling with state agency officials, and we'll be joining the Carter Center and Eve in that effort and talking to folks at our Department of Insurance and our Department of Community Health. And we have a great partner in Wendy Tygreen, who is here in the room, who's been really just very open and generous with sharing information about what she knows is happening in the agencies. So we're going to explore what's going on there, so we have a little more depth to what's happening here in Georgia, not just at the statutes, but in the regulatory environment and in implementation and enforcement that may not be as formal as being legislation. And so we hope to take all of that information, put it in something that's understandable for advocates who don't want to spend months understanding the nuances of parity, but also, yes, and also for consumers. And really build a roadmap forward. So how do we move Georgia from a D to an A? We know we can't get there in a year. We know we can't get there in probably 2 years. So what are those middle steps to move us from where we are to where we really want to be, and what does that look like? And so that's kind of what we're looking at doing right now. We expect to put that out in the summer. We do have a couple of initial learnings that I think I can share. And of course, take these with a grain of salt because we still need to talk to our state agency partners. But one thing that we found in our talk with advocates and doing initial research on parity is that the states that are leading the way do have state legislation, recent state legislation. And while we know that Georgia's state agencies are empowered to implement and enforce the federal law, they have as much power as they need to be able to do that. Often they need a little bit of a push and support and to know that they have the endorsement of both the executive branch and the legislature. And so often legislation is needed. So it is likely that our roadmap will recommend at some point legislation, although likely not a first step. We know that consumer education and increased transparency are not going to be the solution. They are always a part of the issue. But as Ben very eloquently put it, most of us really struggle with understanding what a deductible and a copay are, much less co-insurance, which is more regularly a part of insurance these days, especially private insurance. And thank you. And so asking consumers to understand what behavioral health parity is and to determine whether they are experiencing parity in their own insurance product is unreasonable, and we shouldn't place that burden on them. They are struggling hard enough to get access to the care they need when they need it. And so that while consumer education will play a part, it is definitely not the primary solution. And then our kind of third initial learning is that Georgia state agencies may not be resourced in a way that allows them to implement and enforce parity in a complete way. So I'm thinking very specifically about our Department of Insurance currently. Over the last number of years, they've really operated with a lean and mean team over there. And and in conversations with Commissioner Beck, he's been very frank with me that they really just don't have the staff to do the very in-depth analysis on private insurance products to make sure they're compliant with parity. So without those resources and the staff and expertise in the agencies that are tasked with enforcing and implementing the law, it's very hard to move forward. So those are kind of some initial findings. As I said, we will have a more complete picture with very complete recommendations later this year, ideally this summer, and plan to release that as widely as we can. We view the result of this work as a collective resource for health advocates like ourselves and our behavioral health partners. We know that GHF will not be the only organization advocating and pushing this forward, and so we really want the information and recommendations that we lay out to be useful for everyone that wants to move parity forward in the state.
So Chris is going to talk to us in a minute about why this is important, but I would like to follow up on a couple of comments that Cindy made. So one, our insurance commissioner is brand new. He's been around Georgia politics a lot, but he doesn't know much about mental health yet. So there's a particular opportunity to say, here are your broader powers, and we'd like to ask you to do some very specific things around parity. And then I'm going to try one more time. So, Tally stood up this morning and said he couldn't make orange juice because he couldn't concentrate, right? So I help make sausage. I can prevaricate and supplicate. But one of my favorite receivers of that supplication is Sharon Cooper, who's the head of our health committee. And she's deeply interested in mental health. So if you don't know her, I want you to, she sat through the whole day, which we all deeply appreciate. She's a psychiatric nurse and taught nursing. But when you talk about health issues, Sharon's the leader. And so if you don't know her, I want you to introduce yourselves to her before you leave today.
And I just want to add one note about my comments. I should clarify, so we're looking at both Medicaid and private insurance in our paper, so we'll be trying to address both at the same time.
Chris, tell us why all this is important.
Okay, hi everyone. That's kind of a big step. They didn't tell me I had to do that. My name is Chris Johnson. I am a person in long-term recovery. What that means for me is it's been a little over 10 years since my substance use or mental health concerns have prevented me from leading a full, active, productive, and rewarding life. Thank you. Today I have the great honor of serving Georgia's mental health peer community as Director of Communications for the Georgia Mental Health Consumer Network. And while I have served Georgia's behavioral health community in a number of capacities, today I'm just here representing me. They asked me to come and share a little bit about my personal experience as a Georgian in recovery, and that's what I'm doing. I did not take a poll, I didn't ask around the office, how has Parity affected you? Because it wasn't a question I really understood at first, and I didn't want to try to explain it to folks. But I gave it some thought, and to me, Parity, mental health care occurs in a cultural and social context. It's not just about the explanation of benefits that we get in the mail, which, again, always a mystery. It's like, thank you, or always a mystery. But so I'm going to give you a little context about my life and how I've experienced Parity. In the fall of 2008, I was a tenure track professor at a university, and I experienced a mental health crisis which required a brief hospitalization. 2 years later, despite having a tenure portfolio which should have sailed through review committee and with the support of my colleagues and department, I was denied tenure. And my department chair and colleagues appealed to the college dean and the provost, and they wouldn't budge because at that point I was a perceived risk. I was someone with mental health concerns, and while that was definitely not put in the letter I received, that was really it. They were happy to let me stay on and teach full time, continue doing the research, continue doing all the service to the college, but no tenure for you. And I chose to leave teaching at that point, and I went to work for the local community service board, and as an addictive disease support specialist, I learned firsthand, and for the first time, the really significant barriers that so many of my peers face. For instance, when I was trying to enroll folks in Obamacare, I learned how many of my peers have never used a mouse or a keyboard and had very limited, if any, understanding of how email works. But that was good practice for me. In 2016, I came to Atlanta to work for the Georgia Council on Substance Abuse and enrolled myself in Obamacare. And I was very excited when I moved here because I saw all of these, hundreds of mental health providers in the Atlanta area who were on my plan. And, I assumed it would be very easy to get care here. And talk about country come to town, y'all. It was really amazing. Most providers just had outgoing messages saying, we're not accepting new patients. Don't leave a message. I lost track of how many messages I left for folks that were just never returned. After months of after a few weeks, I finally got through to a person at one of the public treatment centers, and they said, what you have to do is you have to show up at 6 o'clock in the morning, and you have to wait, and you wait a few hours, and maybe you'll see a physician, and if you can't, you just have to come back a few days in a row. I said, well, I have a job. I really can't do that. So eventually I just convinced my primary care physician to prescribe my mental health meds for me. Late last year, as I started looking for new mental health services here in Atlanta, I realized the situation really hadn't changed that much. Even being willing and able to pay for out-of-network mental health services, it took me 6 months to get a new patient appointment that, could fit in my life. And, that's just not okay. The lack of providers here in Georgia, where we have one of the lowest quotients of behavioral health providers per capita, in the country, means that while parity is a great concept, it does not equal access to care. And that's really what we want, is what I want for me. My experience of parity so far feels like, I've been out in the desert, desperate for water, and a supply helicopter comes by and it drops out a coupon for 50% off a Frappuccino at the nearest Starbucks. It's just not what, it's not that it's not related, it's not that it's not helpful in concept, it just doesn't solve the immediate problem that I need and that so many of my peers need, which is access to mental health care. I learned through my time working at the Community Service Board how really privileged I've been in my life. I have good education, I have the ability to advocate for myself and the skills to navigate the American healthcare system for the most part. I have been insured since June 6th of 1990. I've not gone a day without insurance. But I can say that, for me personally, without question, access to mental health care has been, more challenging now than at any point in my adult life. My interactions with, thousands of Georgians in communities across the state since 2016, when I went to work for the Georgia Council, have really demonstrated to me that, there are many challenges to equitable behavioral health care for Georgia citizens, especially our rural and impoverished citizens. It's just not there. Parity is great, but when you look at any map showing access to care, Georgia just doesn't look good on any of those maps. The Bureau of Labor Statistics, shows whole counties where you're like, what do the people in those counties do? Traveling across the state from Rome to Jessup to Albany to Augusta, Cedartown, Carter, all those places, I know that our neighbors want to help and support their neighbors. I have seen that. Georgia, we care, we do. We want to be there. But I also know that stigma is pervasive. In 2008, if I'd been in an automobile accident or had a heart attack requiring hospitalization, I would probably be a tenured university professor today. Instead, I'm here with you, and I am honored and thrilled to be here with you. I love my job. I love the work I get to do today. But my story could have been so different. If I had been a single dad with 2 kids and a mortgage I couldn't get rid of in a small college town with few career options, where would I be? If I didn't know how to use a mouse and a keyboard, where would I be? So again, I'm really glad I'm here with you. I have heard the stories of those other people, a lot, and I have wept with them because I can't fix the system alone. None of us can fix the system alone. That's why we're here. That's why we're doing this work, so we can do it together. And that's why I'm sharing some of my story with you, because I know, just to echo what Jason, Mr. Carter said this morning, it is those stories that make the difference. Earlier this week, I was at a social media conference at the Marriott Marquis and met a lot of great people. At lunch one day, there were 7 other people sitting at the table, and we were talking about what we do, and I shared what I do. And within 10 minutes, the other 7 people at the table all shared a story of mental health. Either them or a person in their immediate family, a health concern and access to mental health concern or mental health care. I know we have a long way to go, but I believe we can get there. So thank you.
Thank you. It's come up a couple of times today. You can't see who's still in the audience, but the mental health person power issues are extensive, particularly in the rural areas. Some of more telehealth, some of the kind of interstate compacts are trying to address some of those shortages. There's also some efforts to, well, we had one last couple of years, we've added some residences for psychiatrists. So then the medical schools are getting more interested. So that, those are important things. They're sort of small steps. They're not big enough yet, but we've gotten a good start. I don't know if Jackie's still here or not. There she is. So Jackie has a family foundation involved in several members of our foundation community who have also decided to focus on having enough mental health professionals to help all of our citizens. They're particularly interested in children. But there are multiple efforts that have gotten started, and I'd certainly encourage you to take one on. If you're looking for a mission, we can find it. So, any event, we were first going to ask the panelists if they had questions of each other. Well, there's that dumbfounded 4 o'clock look, So we can talk for a long time, as you can tell. I mean, two of us are lawyers, 4 of us are lawyers. I mean, it's scary.
I'm a psychologist.
Not a lawyer.
He can listen forever.
Chris, I have a question for you because I really appreciate the honesty and candor you brought to this. It really grounds it, and thank you for that. When you are out there talking to the folks that you're trying to help and you're advocating on their behalf, how do you best instill hope, knowing that we're up against such a huge fight to change this behemoth of a healthcare system? What are your talking points that you can give us so that we can keep people moving forward?
I think the talking points are actually listening points. Listening to people and really hearing what their concerns are, what their needs are, because we, as a society, as a culture, we really don't listen to each other. And I think just by listening, there's an exercise we do in lots of our trainings called a dyad, where we sit and just listen to another person for 2 minutes and allow that other person to speak for 2 minutes. And it really is shocking when you experience it to have someone listen to you and look you in the eye just for 2 minutes, because it almost never happens. And people feel heard, and when people feel heard, they feel a change and they believe that change is possible.
Pretty powerful. Any questions from the audience? Thank God. Eve.
Not
So
now.
what's so great about Illinois? How did it get great?
There you go. There's a good one.
Well, one big factor with Illinois was that the advocates in Illinois had been, had their eye on parity, and especially, working with a lot of the organizations that we had included as our expert advisory board to help us identify what those 10 categories are that we should be measuring. Illinois was listening and, passed a law actually that was effective as of January 2019 that hit all of those categories. So that was a very recent change and really had to do with the, grassroots advocacy that was happening in that state to get the legislation passed. So I didn't know about Colorado, so
Yeah,
I'm excited to look at that one.
Well, I was joking earlier about the cut and paste thing. It's that Colorado really did model much of what it did after Illinois. And it was the Mental Health Colorado Advocacy Organization, which I'm on the board of, that really took that and ran with it. And surprisingly, I have to say, and I don't want to kind of jinx anything here, but the opposition to it was almost non-existent. It's that at this day and age in 2019, to be able to enforce and add transparency to a process that's so bewildering to thousands of people, a lot of people, it resonates with folks. And so the opposition was not as strong as I think we were initially anticipating.
I might close with something that's sort of implicit in what we're all talking about. As an advocate, I want you to pay attention to the financing. So you can't be effective in the General Assembly unless you can take something you want and add to your position that I think we could pay for it this way. And it just, insurance is one obvious example of that, but there are multiple other ones. So sometimes it's, if we did mental health better, primary care would be better. If you're not able to listen to your doctor and do what he says, or you don't want to go back, or you're only using the emergency room, it doesn't work very well. Private insurance pays for people, for self-pay people. If it costs $100 to deliver a service, Medicaid pays $75, Medicare pays $85 to $90. And 10% of people don't pay anything, and insurance pays $112, and sometimes it's $130.
And
So,
for those that are uninsured, we are seeing that in our emergency
Right.
department costs.
so I'm just using that as an example of how you learn how to talk about what it is you want. If you can't do that, if you can't finance something at the state level, it won't happen. It's very important.
Great. Thank you, panel. Thank you, Stan. Maybe I'll have you come back. Yeah. Just teasing. Stan's around to stay. Well, thank you all for staying till the end. I'm not going to say the bitter end. I think this is the beginning, actually, with activities moving forward. We shared with you today a lot of good work that's been done and concluded, and the momentum about improving and continuing to improve. Parity is one of those areas. As complex as it is, I think we'll make great progress in the years the years to come. I also hope very much that you leave feeling, even though it's 4 on Friday, energized and hopeful. There's such great momentum, and if I heard anything today over and over, I'm really missing Mrs. Carter right now, because those of you annual participants, she did this phenomenal job of summarizing, and I'm not even going to try, and I apologize. But she takes notes and would do this wonderful summary. But I will summarize in that what keeps coming back to me is something that Stan's wife, Bobby Cleveland, with Toll Foundation, has said to us in a recent meeting, that it's whole child, and I want to say whole person, and whole community. And I think we heard numerous examples of here how it's cross-sector collaboration, it's involving the community, faith, all of that. And we're just, we know that, but somehow it just really feels like we're ready and we're doing that now. So thank you all very much for coming to the Carter Center. Wishing you all a wonderful weekend. Happy Mother's Day. And we'll be in touch. Thank you.